Yeah. Good evening, everyone. Greetings from IAP Gujarat for this e-Gurukul Pathshala, which has been running since almost I think 3-4 years that it has been running. On Saturdays we do this program from 6 to 8, when usually we have cases being presented or sometimes seminars or journal clubs being done. The most common thing is actually that we would usually do uh, a case presentation. So this is the most commonest one which is there. Today I am actually standing in for Dr. Nehal Patel, who is professor and HOD of Solar Gymmers, who kind of coordinates the program, and Dr. Baldev Prajapati, who kind of moderates the entire program. So I'm essaying both their roles today on their behalf, and I look forward to a very engaging presentation. Today we have Dr. Shruti Mistry, who is presenting a case of a newborn, and Dr. Aditi Parikh, who's a mentor. So Dr. Aditi Parikh is an assistant professor at NHL Medical College, Ahmedabad. And just a brief, I'll give a brief about. I actually don't know whether I have the PPTs of the faculty members. Uh, does Clarinet have the PPTs of the faculty members? If not, I will share their PPT. Let me just check the short CV.
Sir, I don't have the PPT, but you can share with me. I can told Ruksha to play if you
Uh,
allow.
uh, that's fine. That's fine. So I'll just share it right away. Okay.
Okay,
So
okay. Sir, you can share me over WhatsApp on this
uh,
number,
uh,
on the number.
can you allow me sharing rights on the Zoom?
Yeah, yeah, sure, sir.
Uh,
Ruksha.
yes, sir. Yes, sir. Sir, you can share it from your end, sir. Yes, sir. It is sharing.
We have
It is
Dr.
visible, sir.
Subhash Chandra Saw, who is professor of pediatrics and neonatologist at Army Hospital Research and Referral, New Delhi. Uh, he is MD and DNB from AFNC and DM Neonatology from AIMS New Delhi, and has completed his FAMER from CHGS Medical College, Mumbai. I've been working with him for this past year, mainly as an editor in Journal of Neonatology, and he's also associate editor for Medical Journal Armed Forces of India. So it's a pleasure to have you, Dr. Shaw, for today's presentation. The next uh, expert that we have today is Dr. Rabindran Chandran. He is currently the senior consultant neonatologist at the Ramchandra Institute of Higher Education and Research. He's completed his MBBS and MD from Chennai and Cuttack, and PhD in neonatology from Rainbow Children's Hospital, Hyderabad. He's also done his clinical genetics fellowship from CMC Vellore, and now he is an assistant professor at Pondicherry Institute of Medical Sciences, and has a total of 15 years of academic and research experience. I hope both of our experts can share their views and guide the case as it flows. Thank you very much to both Dr. Shaw and Dr. Chandran, because I requested them relatively last minute, and they have agreed at the last minute. So I hope I'm sure that we will be able to have a wonderful discussion today, and I think we can just proceed with the case. So Shruti, I can share the case, right? Or is that correct? Huh? Yeah, or can you share the case, or you'll
No,
find it
sir,
difficult?
you said.
I
No,
should.
no, sir, you said. You should say.
Okay, okay, fine. I'll do that.
Oh,
And so, as Dr. Ravinder mentioned, don't worry about all these initial things. These all things happen, very common, and just
yes, sir.
relax. And a brief for the experts, Dr. Shaw and Dr. Ravinder. We can interrupt on any slide or every slide and ask questions, just like we do in a physical case presentation. So that would help, and we also interject in between. So that's fine.
Oh,
Dr. Shaw and Dr. Ravinder, can we get started?
Sure, sir, sure.
yes.
And except for three of us and the student and the mentor, request everyone else to keep their videos off. Okay, Dr. The mentor, student, and the three of us. Thank you. Please go ahead.
Good evening, sir. Good evening. Today is my case presentation on newborn, sir. I am a resident, third year resident from NHL Medical College, sir. So next. My patient is baby of Ashwiya Banu, 17-day-old female neonate born to 25-year-old primary mother residing at Bahrampura, Ahmedabad. The neonate was preterm, 32 to 34 weeks according to Ballard. LSCS delivered, CS delivery because of emergency, DCDA twins, and there was arrest in second stage of labor. Uh, and delivered at 7:24 p.m. on 3rd February 24 at SVP Hospital. Baby cried immediately after birth and presented with the chief complaint of mild respiratory distress, preterm, and low birth weight care. Hence, patient was admitted in the NICU immediately after the birth. So next slide.
Hello.
Yes, ma'am.
Sir, very sorry to interrupt you, but sir, can you make the PPT full screen? Sir, can you hear me?
This is on presentation mode.
Yes, but sir, will you be able to make it full screen?
Yeah.
Yes, sir, this is what I'm talking. Thank you, sir.
Next slide. I would like to proceed further with antenatal history.
So any questions on this particular slide, or we can go ahead?
Shruti,
Yes, sir.
I firstly don't get nervous. I mean, those
Yes, sir.
technical things are just nothing actually. Okay,
Okay.
so I just want to know what about the other baby? You just wrote about one baby only.
So there were
The other
twins,
twins?
both were females, DCDA twins, and the other baby was 1800 grams, and that was also admitted in the NICU for respiratory distress, and it is
Oh,
currently also in our NICU.
okay, fine, fine. Okay,
Okay, we'll go to the next slide.
please go ahead.
Antenatal history. Maternal age is 25 years. Active married life is 1 year. Non-consanguineous marriage. Maternal blood group is O positive. No fertility treatment was taken. This pregnancy was spontaneously conceived. LMP was 11th July 2023 and EDD was 18th March 2024. Mother was primary and HIV and triple marker were negative for this patient. Next.
So I have a question. Why did you ask for fertility treatment taken? The marriage life,
Sir,
1 year only,
uh,
no?
yes, sir. It was because of DCDA twins, sir.
And uh, uh, when do people start fertility treatment? Generally, what is the definition of fertility? Is there any definition per se?
Uh, so when age is less than 35 years, no spontaneous when people are not able to conceive in after unprotected intercourse within 6 months and after within 1 year, sir.
Okay, I don't know. Dr. Shaw or Dr. Ramandan, would you be able to share like when people would usually take fertility treatment? Because this is something which I heard that a lot of people end up taking fertility treatment quite early rather than when it is not even necessary.
Dr. Shruti, actually, we can call this fertility as a primary or a secondary infertility. So, with a married life of 1 year, we don't, what Sarah is trying to tell you, the concept of, yeah, I am happy that you just broke history, whether because of a twins, you're going for a fertility. But usual in our current scenario, at 3 years of marriage, the prolonged period of marriage, and they'll be anxious to conceive. The term they use is anxious to conceive. So if the same mother is presenting after 5 years of marriage, you can tell that was anxious to conceive for 5 years. Then she undergone a fertility treatment. So the word anxious to conceive we have to use. But logically, do you also agree to a statement that 1 year is a very short period, Nama,
Yes.
to go for a fertility treatment? But I am happy that you, being a twins, you are happy. Your concept of more amount of twinning in assisted delivery, assisted conceptions compared to a spontaneous conception. Agree, I'm happy that. But usually, it happens 3 years primary infertility. There we go for a specific treatment, assisted delivery. So still, I appreciate your terms that the concept of twinning is more common in. So can you just tell me why twinning is more common in assisted deliveries?
So because of ovulation induction, hormonal injections, certain times clomiphene citrate is given, which can lead to stimulation of multiple follicles.
Very good.
And yes, sir.
The success of fertility center, they already want to have delivery, but any means. That is the reason they have 3 or 4 sites to
Yes, sir.
get. That is the reason they land up in twins most of the time. It's right.
Yes.
So I had another question. If any Dr. Shaw wants to ask on this slide, any other thing?
Yes, firstly, that's a WHO concept actually, that 1 year of unprotected sexual exposure. After that, also, if there's no pregnancy, in that case, you can call it infertility. That way, you are right. What are the problems you anticipate in case of twin pregnancy or any multiple pregnancy, let's say?
Sir, small babies, prematurity, preterm labor,
Okay.
uh,
Yes.
low birth weight,
Yes.
uh, preterm prematurity, low birth weight. Chances of congenital infections are more.
Not infections, anomalies, you can say.
Yes, sir.
There's some reports that
Okay.
there may be, more chance of congenital anomalies, though it's not very robust evidence. But yes, but prematurity, yes. Low birth weight, yes.
And
Some evidence is there for more chance of CP
yes,
and
sir.
more chance of congenital anomalies, but not infection. Yeah.
Okay. And sir,
Yeah.
in mother, multiple pregnancy can lead to preeclampsia, uh,
Yes.
hyperemesis gravidum.
Yes.
Good. So I
Yeah.
had another question. You talked about HIV, hepatitis B non-reactive. I'll not ask why this was done, but something which normally is done is not written there. So I was wondering whether it was done or not. In most pregnancies, when we did our MBBS, we used to write this test is non-reactive. That is not there here.
Other than HIV, HBCG, the third one, sir, is asking.
Hepatitis C, we do here hepatitis C.
No, hepatitis C, we don't do. matlab, It's okay. VDRL, you have
Real.
heard of
Yes,
VDRL.
sir.
Was this done in this case?
No, sir, not done.
So because I think a lot of people are not doing it. I don't know for what reason. I find it not being done. But and
In
there have been cases of syphilis which people have recently said कि they are seeing syphilis now. So there's something. And why would you want to do it?
Uh, syphilis.
So I think both of them can get treated straight away. Actually, and HIV also would get treated and would help. Hepatitis B,
Mm,
as far as I know, I don't think it helps either the baby or the mother. It just allows you the that you can ensure that the baby gets HBIG and hepatitis B vaccine as early.
sir.
Uh,
Okay,
that's fine. Go to the next slide.
okay. Mother has taken regular antenatal visits. 2 tetanus toxoid injections were taken. Iron folic acid supplementations were taken. Antenatal USG was suggestive of DCDA twins, and no other abnormalities were seen or documented in antenatal USG. Antenatal steroid coverage was given. Maternal systemic illness. There was no history of diabetes, hypertension, or any other cardiac disorder to mother. Mother had history of hypothyroidism since 5 months, and she was being treated for the same. She was on the tablet thyroxine.
Okay, you have written antenatal steroids were given. When were they? When was it given? And like
Uh, uh,
in this case, when was it given? What was the indication? And then I'll ask
sir,
something.
okay, sir. Sir, twins, and it was given around 33 weeks, sir. Betnazole coverage was given.
So you mean to say, steroids were given at 33 weeks without any indication?
Sir,
Or in
if they
other,
are
okay, in
suspecting preterm labor,
so you okay, fine. So what are the indications of giving antenatal steroids? Let's come to this answer and then we'll go to this case.
uh, sir, when there is delivery is anticipated in
Yes,
less than 30 to,
preterm.
yes.
In which age group or which period of gestation antenatal steroids is indicated and when? So in 24 to 34 weeks, between 24 to 34 weeks, antisteroids are given. Okay. And in that, there are some scenarios when it should be given. It's what I mean to say that once it is twin pregnancy, it's not that all babies will be all mothers will be given antisteroids at 33 week or 32 week or 28 week. Nothing like that. There has to be a setting where antisteroids need to be given. So what are those settings? One, you said no, that anticipated preterm labor. Okay. What are the other settings or indications of giving antisteroids? Like leaking per vagina.
Yes.
Okay.
Yes.
Then also there's a chance, no, that there can be preterm delivery and or chorionitis or something developing. So they have to be covered. Then bleeding per vagina in that period, 24 to 34 weeks, no? Or
Yes.
sometimes maternal things like if my mother is having hypertension, let's say, okay,
Yes.
140/90, more than 140/90, then also they will be giving because anytime, the pregnancy might have to terminate it if the BP goes high or, mother goes into preeclampsia or something, no?
Yes.
And
Yes.
also if it's being contemplated that the babies need to be delivered, like let's say one of these or both of these or whatever they develop, let's say reversal of endogastric flow or absent endogastric flow. I hope you have heard about those terms,
Yes, sir.
absent
Yes, sir.
reverse endogastric flow.
Yes.
So whenever
Yes, sir.
a termination of pregnancy is being contemplated for maternal cause or for fetal cause, whatever we discussed so far, they are the triggers when antenatal steroids need to be given. Okay,
Yes. Hmm.
fine. Okay, so
Yes,
what
sir.
all antenatal steroids you know of which mother should get?
Uh,
The mother is
Betnazole, Betnazole and dexamethasone.
This patient got betamethasone, so
Yes,
maybe
ma'am.
Dr.
okay.
Shah, we can ask her why betamethasone is good or bad.
Yes, so in betamethasone and dexamethasone, first tell us what are the dose it needs to be given. What is the
So
dose of betamethasone? What is the dose of dexamethasone?
dexamethasone 6 milligram, 6 hourly,
12
and
hourly.
12
6 milligram 12 hourly. How many doses?
dexamethasone 4 doses, betazole 2 doses.
Very good. So what is the dose of betamethasone?
Sir, 12 milligram.
12 milligram. And like when do you repeat? How many
22
doses?
doses,
24, 24
24 hours.
hourly. Correct. So Dexa is 6 milligram, 12 hourly 4 doses, and betamethasone 2
12
kg,
milligram,
4 hourly 2 doses.
12.
Correct. Yes. Why is it given? Why antisteroids? Wow, what does it do?
To improve the lung maturity of the fetus. So after birth, lung respiratory distress related complication reduces. Even a single dose reduces the complication after the birth. In
Very good.
case of in case of neonate birth.
Yes. So does it have effect only for lung maturity or something else also?
But I don't know about
You're not
the.
aware? Okay. So antisteroids is something everybody needs to know about it because it actually has made the maximum change in neonatology. Okay. So today, because of better antisteroids coverage, we are seeing far less complications of whatever complications you know of. Okay. So like what are the complications of prematurity like other than RDS?
Sir, sepsis,
Sepsis,
NEC,
NEC,
uh, uh,
BPD, PDA,
yes,
no?
yes,
Then IVH. So
yes,
other than BPD, probably it reduces all the other complications, right?
okay,
So RDS, incidence of PDA, incidence of NEC,
okay,
incidence of IVH, everything is reduced. Fine.
okay,
In BPD also it should have reduced, but probably more babies survive. So BPD, you don't see the change. But it
yes,
has an effect almost for every complications of prematurity. So if any wonder drug is there, it is this. So that's why it needs to be known, the correct indications and what does it do and what are the doses and all. So that even at the grassroots level also somebody should be knowing the implications of giving and must give when indicated. Okay.
yes,
Yeah. Please carry on.
Yeah, so Dr. Rabindranath, I think, wants to speak, right?
Yeah. So,
yes,
can I ask a question? Just
sir.
if the baby is a small baby or a big baby or normal baby?
SGA, sir.
Okay. Taking this history into consideration, and what are the factors favoring SGA? Can you just tell me why SGA?
Sir, after birth, I plotted the weight on Penton's chart and it was less than 10 centimes. So,
Very
sir,
good, very good.
SGA.
What are the reasons? Why do you think the baby is born?
Just because of twin pregnancy.
Okay.
Uh,
So it's very good that you told because of twin pregnancy.
yes.
So then I should use a separate chart number for twins. Should I use a separate chart or should this common chart I should use?
Sir, actually, I am not aware of the separate chart in
Okay,
case of
right.
twins.
That's
Sir, we use Fenton's chart at
right.
our
Very good, very good.
analysis.
Very good. You're correct answer. But up to 28 weeks of gestation, a twin and a singleton grows at the same speed.
Okay.
Up to 28 weeks. Okay. After
Yes.
28 weeks, compared to the placenta, baby size increases.
Okay.
Compared to the placenta, baby size increases. So there
Yes.
the competition starts. After 28 weeks, the
Yes.
growth you have to use a separate chart. But usually we use a pattern chart. So I'm happy that you use the word pattern chart. What type of growth chart it is? Not pattern chart. Pattern chart. I'm happy that you use the pattern chart. What type of growth chart it is? We are commonly using for preterms number. So I'm just giving a clue. It's the intrauterine growth chart, extrauterine growth chart.
Okay.
I'm just asking you. It is the intrauterine growth chart or extrauterine growth chart? Well done.
Sir, extra you try.
I'm just asking the growth chart. The growth chart has got a dip and goes above, or it directly goes like this? Pattern's growth chart. On seeing the graph goes down and climbs or keeps on going parallelly.
Yes, sir.
So I make a simple example to you to how to differentiate a chart. The chart is keep on going straight like a step ladder, like a growth
Yes.
chart. That means the baby is not born. The graph is plotted by the scan reports. I do a
Okay.
scan for 128 weeker. I do a scan for 129 weeker. I scan for 130 weeker. Out of the
Yes.
100 cluster, I take one central point. I keep on plotting because the baby is not born out. The normal dip in growth is not there. So anywhere, any chart you are seeing, there is no downward and going above. It is a intrauterine growth chart. It is plotted by the scans. Extrauterine growth chart means baby is delivered outside. Baby loses weight. Why babies loses weight initially? Why do you think?
Just because of extracellular fluid loss some days after the birth, and then baby again start gaining weight.
Excellent, 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 excellent. So baby's blood volume and the total water is 80%. Our water is 60%. Baby loses 20%. So baby loses down. So when you see a graph showing a downward and going climbing above, it is a extra uterine growth graph. It's clear now? Can you repeat what is
Yes.
the intrauterine and extrauterine growth charts?
Uh, Sir, in intrauterine growth is uh,
There is no dip.
no
Keeps
dip,
on
and
climbing. Keeps on glowing.
yes, sir.
Extrauterine is
Ma'am, after a dip, there is again
very good.
rise.
So any chart you are seeing in the exam, if there's a downward and going, it is extrauterine. It is straightly going, it is a intrauterine. Okay. So that completes. Now, what are the negative history? I showed beautifully. There's no history of diabetes, no history of hypertension. Do you
Yes, sir.
think these are factors causing small birth weight?
Yes, sir. Diabetes can cause SG, IUGR, placental insufficiency, sir.
Very good. And
Uh,
hypertension?
Hypertension also can cause placental insufficiency, sir, and it can lead to IUGR and SGBP.
Excellent. Right.
Okay, can I come in there? Just one query. Yeah, so does diabetes cause a small baby or a large baby?
It can cause both, sir. I have read in the Cloharty. It can cause LGA baby due to increased insulin level in baby, and that leads to LGA. Just because
Very
of increased sugar from mother, it goes to the baby, and just to get down the sugar levels, baby produces large amount of insulin, which in turn leads to LGA baby, as insulin is growth promoting hormone.
Very
And
good.
I have
Very good.
also read diabetes can also lead to placental embryopathy, which can
Yes.
lead to IUG or SGA baby. I have read in
Very
both OBGY and
yes.
pedia.
Very good. Very good. So it can cause both, though causes more of a large baby, but if in case
Yes,
diabetes is severe or overt
yes,
diabetes kind of thing, in that case it can cause small baby as well.
yes.
Good. Fine. Yeah, carry on, please.
So
Dr.
next
Ravindran,
is
you want to talk about this? This is what you wanted to show, right? This was your clinical
Can
chart.
you just comment about the curve now? Now you're
Yeah,
able
yeah.
to see the curve.
You can see.
It is,
Yeah, yeah. Please comment. You can comment, please.
I just want to see the curve, and that it is going down and climbing or directly climbing.
Directly climbing. You can see that weight is directly climbing. I will show you the extrauterine chart because you had mentioned, right? So I thought I'll
Yes,
yes,
yes.
pull them down. I will show which is this is the one. Yeah. Can
You
you
can
see
see it
now?
beautifully. It is
yes,
coming down.
yes, sir. And then
Okay.
it's going.
So this was the
So,
postnatal one. That was the previous one.
so
Correct?
this yes sir. This graph is plotted by plotting the postnatal weight of the baby. So one baby on day one baby on day 14, one baby on day 28.
Yes,
They
sir.
keep on plotting.
Yes,
The
sir.
previous graph was a scan report, and the scan baby is not born. 28-week
Mhm.
baby inside the mother uterus, 100 babies they plot. Then again 29 weeks, the 100 babies they plot. That is the way they don't have the depth. Can you understand?
Yes.
Thank you, sir.
We will go back to the presentation. Uh, just give me a minute.
Okay.
By the time Sarah is putting, you put a blood group O positive. Do you think that is
Yes, sir.
important in this case?
Yes, sir, it is important. I have seen cases of neonatal hyperbilirubinemia just because of ABO incompatibility, and I'm not sure of the source, but sir, I have heard somewhere in O positive mother there are antibodies which reacts with the baby's antibodies is passed through the pregnancy in last trimester, which reacts with the baby's RBCs, and it leads to early hyperbilirubinemia.
Sure. Good.
You can see the full screen, right?
Yes, sir.
Okay, I have questions on this still.
Yes, sir.
You've written 2 tetanus toxoid injections taken. Do we give
Yes.
tetanus toxoid now, or do we give some different injection nowadays?
Diphtheria. Uh,
So you know
uh,
the answer. So it's DT injections that we are giving now.
yes. Yes, sir.
You wrote tetanus toxoid because even a
Okay.
habit,
Yes,
this
sir.
habit picked up from MBBS, which has continued, though there is a change in
Yes.
policy
Yes.
that you know. And another question is this thyroxine. I have
Yes.
not understood this. Did the mother have hypothyroidism since birth, like since infancy, or
No, 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 sir. In the pregnancy.
okay, in the last 5 months? So that's the
Yes.
I wanted. All right,
Yes.
we'll go to the next.
Maternal pregnancy related illness, no history of fever with rash, pregnancy induced hypertension, jaundice, gestational diabetes, bleeding PV to mother, no history of prolonged leaking PV, no history of drugs or radiation exposure during pregnancy, no history of alcohol ingestion or smoking or any major addiction, no history of any blood transfusion or any major surgery in the past.
I don't think we want to ask any questions here.
Yes.
I would just advise a small thing just for improving your antenatal history. Try to club them semester wise. It
Okay,
becomes more,
sir.
you know,
Okay,
like
sir.
let's say you are coming back to drugs and radiation exposure, which is actually important for the first trimester when you
First
were talking about
trimester.
iron and folic, sorry, not
Yes.
iron, folic acid. So something like that. So first trimester problem, second trimester, third trimester, it becomes easy for you also to remember and it looks nice. Okay, maybe
Yes, sir.
next time you can do like that. Okay,
Yes.
yeah, carry.
Birth history. Spontaneous onset of labor at 34 weeks of gestation. No blood stain or false membranous liquor. No prolonged rupture of membranes. Due to there was a second stage of labor, deep transfer arrest was there. So emergency LACS was taken. Baby cried immediately after birth and the birth weight was 1335 grams. As patient had signs of mild respiratory distress, patient was admitted in NICU for respiratory distress and low birth weight care.
Any
Yeah,
questions?
just one question. If
Yes.
the baby's weight is 1335 kg,
Yes, sir.
1.3 kg, and 34 weeks the delivery pain started.
Yes, sir.
So being a twin, I can accept. If it is a
Uh,
single baby at 34 weeks at 1.3 kg delivery starts, do you think it is normal or something is abnormal?
Sir, in singleton pregnancy, it is abnormal, sir.
So very good. What is a
Yes.
major thing you will keep in mind? Singleton baby suddenly preterm spontaneous onset.
Uh, Spontaneous onset. Any infection to the
Very good.
mother?
Very good. Very good. Very good. So, so the baby's head should be big enough to hit and cause contractions, which is not possible for a 1.3 kg or 34 weeker.
Yes, yes, sir.
So, if it happens spontaneously, means that you have to always keep in the back of mind that
And sir,
spontaneous.
other reason can be due to cervical incompetency in mother.
Very good. Excellent. Very
Yes.
good. That is a little earlier also, not a problem. But this is always better in our setup to rule out underlying infection.
Yes.
So that is important. And what do you think the reason for the mild respiratory distress baby grass got?
So baby is preterm, and it can also be a component of fluid in the lungs, sir. Both can, like picture like TTNB, mild TTNB, which we see in CS delivered patients.
So, if how to differentiate it as a TTNB or a respiratory distress?
Uh, Sir, by history, sir, TTNB in TTNB patients are almost full term and CS delivered 37 weeker. In RDS, we see patients which are premature. Sir, CXR findings, RDS CXR findings is suggestive of hyaline membrane disease, whiteout lung is seen. In TTNB, CXR are almost normal or sun rays or burst appearance is seen, sir.
One more differential diagnosis in a white lung.
Pulmonary hemorrhage.
Okay, very good. Then any other disease?
Protein one disease uh, uh, related to surfactant.
I'm just expecting a very small answer. Any child will have what? Two-year child admitted with cough and cold. What do you think?
Whiteout lung, sir.
No, newborn baby, 2 month, 2-year
Yes,
child coming to the hospital with cough and cold.
yes, sir.
What do you suspect?
Sir, cough and cold, upper respiratory tract infection.
Okay, he's
Yeah.
having chest signs also positive. So what
Uh,
next ray?
Pneumonia, or I will try to rule out pneumonia, Walry.
So newborn pneumonia X-ray and
Yes,
a
sir.
pediatric pneumonia X-ray, both are same or somewhat different. Okay. Can you just describe the X-ray of a pediatric case of pneumonia?
Uh,
How will, how will it be? It will be.
Sir, consolidation. I have seen consolidated lobe of lung
Yes.
or
You mean to say
perihyder.
it is unilateral or bilateral?
It unilateral, it can be bilateral, sir. Pericardiac shadows also I have seen, sir.
Correct, it is. Majority of pneumonia in pediatric is unilateral or bilateral?
You,
pneumonia, pleural effusion is bi-side or one side more common? Is more
One
common?
side.
One side.
One
Very
side.
good. Very good. But in newborn, it is both side equal.
Okay, sir.
So how to differentiate? Why do you think newborn pneumonia is both sides similar? Pediatric pneumonia only one side more common.
Sir, in pediatric, just because of the anatomy of right bronchus.
Okay. Okay. Agency, host, environment. So what is the agent factor in the pneumonia in newborn and adult and pediatric? How a newborn gets pneumonia? How a
Sir,
pediatric?
newborn can go get pneumonia if patient is on ventilator. It can be ventilator associated pneumonia. If newborn is having sepsis, it can be a component of sepsis as well. And if there is a history of premature rupture of membranes, we have seen cases of congenital pneumonia also, sir. Just because of the sepsis component, patient was exposed in intrauterine. After during an ICU stay, we saw that there was
Okay.
pneumonia in the patient.
Okay. The pneumonia bacteria enters the lung by what route
Yes.
in newborn?
Uh,
Through airway or through blood? Newborn
for
baby?
sepsis.
Newborn.
Sepsis.
It's a blood spread.
Yes,
But in
yes, sir.
pediatric, it is airway.
Airway borne.
So in pediatric, it is airway. So one side. Newborn blood is bilateral. Okay. Can understand the difference? Newborn Y baby,
Yes,
newborn X-rays always
yes,
because it is
yes,
hematogenous spread, not a
yes.
airway. Now I give three X-rays. One is
Hmm.
a pneumonia, neonatal pneumonia. One is a RDS. One is a
Yes,
TTND. How
yes,
will
sir.
you differentiate? All three are white out lungs. How will you differentiate? You
Uh,
understand the three X-rays. One
yes,
is a
sir.
TTNB. One is a pneumonia. One is a RDS. All are having same whiteout pattern, bilaterally homogeneous. So T10B, RDS is small lung or big lung?
Small lung.
Small lung. So lung will be small volume.
Yes, yes.
T10B is
Uh,
normal lung.
expanded.
Normal lung.
Normal lung.
And pneumonia also normal lung. And
Yes.
one big lung where you get big lung, newborn condition where the lung is totally hyperinflated lung. Tell me one condition. Baby passes dash before birth.
Meconium.
Meconium aspiration
Meconium.
syndrome.
Meconium aspiration, sir.
So big lung with patches, meconium. Normal lung with patches, T10B or pneumonia. Small lung with patches, RDS. Okay, it's clear.
RDS.
Can you
Yes.
repeat the statement? I'll close my discussion. Can you repeat the statement? Three type of X-rays.
Sir, small lung and whiteout lung, RDS. Uh, uh, big lung and hyperinflated meconium aspiration syndrome, and normal lung and whiteout lung, TTNB.
Right. Very good.
Yeah, Dr. Shruti, very nice. So, I just want to know one or two things. Is that
Yes, sir.
you've written no foul smelling liquor and no prolonged
Yes, sir.
rupture of membrane. So basically, you are trying to rule out what?
Early onset sepsis. If
Early
there
onset
any
sepsis.
if there any risk to the babies.
Yes.
Yes.
Yes. So what does the mother develop in that case? Like, what is it called? That term?
Chorioamnionitis,
Chorioamnitis. Very good.
fever,
Chorioamnitis. So,
fever.
yes. So, yes. So, what are the features of chorioamnitis in mother that we should know actually? That's why I'm asking because we should
Sir,
also be aware if those features are there in mother. Yeah.
fever,
Fever. Very nice. One you have written only for foul smelling liquor that you can say. No?
okay,
What else?
yes.
What else? What are other features in mother? Like the heart rate will increase, no?
Increased
Mother ka
tachycardia,
baby,
yes.
mother baby both, no? So fetal tachycardia, maternal tachycardia, okay. Then
Yes,
maternal leukocytosis, and
yes,
her TMP will rise. Any scar
yes,
tenderness in case previous uterine, any previous cesarean, and of course foul smelling liquor in a setting of prolonged rupture of membranes of more than 24 hours or more than 18 hours, depending upon whichever guideline you are following. So these constellation of symptoms, one should be, looking for it. And in fact, obstetricians are very scared whenever there is prolonged rupture of membrane. They often would look for these signs, no? And immediately, if these signs are there, they will say, okay, this baby needs to be delivered now. Okay, fine.
Yes.
And in the same context, like what sir was asking, is that congenital pneumonia, it's actually that only. It's congenital sepsis, congenital pneumonia. Okay. And always remember those three DDs of whiteout lungs are those three that you said. Okay. RDS, congenital pneumonia, and pulmonary hemorrhage. Okay.
Okay.
And there's no way you can in fact, differentiate between RDS and congenital pneumonia other than those lung spaces. Otherwise, it goes almost hand in hand. So that is why in a setting of RDS, most often all the babies will be on antibiotics, because you can't rule the congenital sepsis out. Okay. They look similar on X-ray. Fine. Yes. I think you can carry on.
So next slide. The baby was admitted in the NICU. Injection vitamin K was given. Patient was kept on oxygen support in the form of nasal prongs and gradually tapered over a period of 24 hours. CXR was done, which was normal. On day 2 of admission, RT feeding was started, which was gradual, and then patient was gradually shifted to spoon feeding and breastfeeding. Septic screen was done at 48 hours, which was negative. Baby blood group was A positive. On day 4 of admission, patient developed icterus and patient was treated for the same. Meconium was passed within 24 hours and urine was passed within 48 hours.
Can you just tell me what are the methods by which we treat respiratory distress? One, you have already told nasal prongs. Any other
Nasal
method?
prongs.
Any other method you
Says
know?
CPAP and ventilator if patient is, or
Very
if
good.
patient has more respiratory distress, we kept patient on a ventilator.
So can you tell me how
NIV,
will?
NIV.
Very good, very good. Can you tell me how to decide on this three? I put okay. I put CPAP. I need ventilator.
Sir, if distress is mild, we generally keep our patients on nasal prongs, or if there is any patient of TTNB, we generally put them on nasal prongs. But if patient is premature and as Silverman Anderson score is between 3 to 6, and premature, so we keep our patients on CPAP, sir, or either NIV mode, whichever is available.
Right. Very good. Excellent. And any other scoring system you know for term babies?
Yeah. Down is
What are the components? Can you try what are the components of term score?
Sir, respiratory rate,
Very good.
air entry,
Very
uh,
good.
uh, saturation.
Cyanosis. Okay.
Okay.
When you see the baby in Silverman Atterman spoon is full of what? Everywhere
Retraction,
the retractions, and one more thing is
nasal
grunting.
flight. Yes.
Grunting. So like APGAR, APGAR, you tell RCGAR. So respiration rate 60, 60 to 80, more than 80. Sinus is not there, sinus is there, improve with oxygen, without oxygen. Grunting is
Yes.
not there, grunting with stethoscope, grunting without stethoscope.
Yes.
Air entry is equal, decrease, absent. No retraction, mild retraction. Score, same score, 4 to 6, 7 to 10, decide on. I'm happy that the answer you told is correct because CPAP is more for preterms.
Preterm.
And nasal prongs and other cannula are for
Preterm babies.
how
Or
much
after
oxygen
delivery.
flow will you give for prongs?
So 1 to 2 liter, 1 liter, 1 to 2 liters.
So what can happen if you give too much of 5 liters of oxygen for prong?
Oxygen toxicity, sir.
Okay, then
Sir, in preterm retinopathy of prematurity.
oxygen concentration. Okay, then the oxygen is dry or wet,
Humidified, sir.
humidified. But everywhere can you get humidified oxygen, or why you want to humidify the oxygen?
Just because it is good for the nasal passage, sir.
Okay.
If we give dry oxygen, it will dry up the
Sorry,
secretions.
these nasal prongs that you gave, because I think that is what sir is asking. it came from the oxygen line on the wall or it came through a humidifier?
Sir, it came through humidifier.
Which humidifier did you use? Fisher and Paykel humidifiers, those ones, the ones which you use in ventilation or CPAP, those ones used
No,
or some
sir.
wall?
No, no, that which are present on the wall.
So there is air or water in it in that chamber, or you keep air, or
Water, just a water.
most people keep just air
Uh,
nowadays because water kind of has a lot of. If you keep water there, in most places, it breeds organisms. So people tend to keep air with it. So you keep water in it, right? Now, and you think it is
yes,
humidified.
sir.
Sir was mentioning about, I think, wet, so humidification. Uh, is that and would that humid passing that oxygen through that? I don't think it humidifies it very well because for actual proper humidification, it has to go through a humidification chamber, which we use in
Yes,
Fisher
the
and Paykel
CPAP.
CPAP machines that you have seen. So proper humidification you have to get through because you have to heat the water for it to get vaporized and get humidified. It doesn't get done so well. So that is one thing. We don't get good relative humidity and then that ones which we give through nasal prongs. But the other main issue is what Dr. Sir is hinting at. It will be cold oxygen. All right. So if you give cold
Yes.
oxygen, it causes hypothermia also. Anyway, fine. Sir, if anything else on this
Yes, sir.
particular.
So just
Right.
have you seen oxygen supply how it is coming in to your hospital in pipe or in cylinders?
Pipe, pipe, sir.
Okay. From central source it comes in cylinders, and the
Yes.
cylinder is in liquid state or solid state or gas state. Or how do you think oxygen will be in what state when it comes to the hospital?
Gaseous.
Oxygen will be the liquid state.
Okay.
In the liquid state, oxygen is transported in the liquid state, converted by heating into gas, so it becomes very dry. That is the reason we have to use a humidifier to make
Yes.
it. So it is liquid converted to the gas. Because of heating, the moisture is gone. That is the reason if you put a dry air into the nose, it can cause unnecessary skin damage. That is the reason we are asking them how much flow you're asking. 1 or 2 liters is okay. 5 liters we go, then there will be a dryness of the mucosa. You're correct. You're correct because it is not good for the this part of the nose. Okay, right, right.
Shruti, may I ask you something? So, in this baby, you gave oxygen and the baby is still premature, no? 34 weeks.
Yes, sir.
So, did you think of giving surfactant? No, I'm asking, you did
No,
correctly
sir.
only. I'm not telling to give surfactant. I'm just asking, when do you think of surfactant?
Uh, Sir, sometimes we give prophylactic in case of patient is very preterm, like less than 28 weeks. And sir, after that, after looking at the X-ray, we decide if there are changes of RDS, we give surfactant, but surfactant should be given as soon as.
Okay, fine. So these days, prophylactic surfactant is almost out. We just don't do it. Prophylactic CPAP is fine, but not prophylactic surfactant. Okay. So these days, actually speaking, these babies are supposed to be taken on delivery room CPAP. Okay, fine. Any baby having distress, you give delivery room CPAP, particularly in a preterm baby. Fine. But surfactant you generally give when there is, I mean, depending on the institute you are working, the need of FiO2. Okay. So
Yes, sir.
some institutes give surfactant at FiO2 of 40%, some should give 30%. Okay. So if the need of FiO2 is more than that, then you give surfactant in a setting of RDS, of course. Okay. Fine. So, and as far as possible, even though these are little like 34 and 34 plus babies, but as far as possible, give minimum oxygen possible. Okay, we are seeing an epidemic of ROP these days. Okay, even this
Yes.
baby will not also be spared. Okay, this baby is 1.3 kg, 34 weeks, so must undergo ROP, and I'm sure you must have done ROP screening. Okay,
Yes.
so oxygen always judicious. Okay, minimum oxygen as far as possible. Fine. Okay. Yeah, I think you can carry on.
So I have another question, and first
Yes, sir.
before that, so have we? Most of us would remember that we used to not use nasal prongs so much. We
Yeah.
used to use what we call as oxygen hoods. We don't use it any longer. Very rarely we use it because now we want to control the amount of oxygen that is given, and Preferably, ideally, we should have given this oxygen through blender rather than directly. So blended and
Yes.
humidified and blended oxygen should have been given ideally. So it's not, this happens everywhere. I'm not saying that this is wrong, but this is what should ideally be done. And and the reason I talked about hood is because I had one of my students in the US who's said that people with a patient with orofacial nasal malformation and they couldn't put nasal prongs. So no one had used a hood there. And so because she did a MBBS here, she was able to get a hood and use it for oxygenating that particular newborn baby because they had never seen a hood being used in the last 20, 30 years. So we tend to forget things. So there are some usefulness of hoods also. So where there are craniofacial malformations, you might be asked to use a hood again. So that's one. And you talked about Downey score, and one thing I don't like about Indians talking about Downey score is they don't mention the other name which is
Yes,
associated.
I'm about to ask. I mean, we should be very proud about that name. It is not
So
Downey score. Downey is something score. Are you aware, Shruti?
No, sir.
It is Downey Vidyasagar score,
Yes.
and Dr. Vidyasagar is from I think Andhra Pradesh,
I,
Unified
I
Andhra
think
Pradesh,
I
and now for the last 60
Dharmapuri Vidyasagar.
Dharmapuri
Yes,
Vidyasagar.
yes. I think it's from Pune or somewhere. Yes.
No, 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 he's not from Pune. He's from Andhra.
Okay.
From
Okay.
Andhra.
Okay.
Telugu speaking. So he went to Chicago in 1960, and that this score is very important for other reasons also. So there's a bit of history. 1960, 62, actually neonatology started, and in like getting more attention. This is following death of baby of Kennedy, who was
Kennedy.
the United States. His wife gave birth to preterm baby, did not survive, died. So a lot of research support. What happens everywhere when politicians are affected, things start happening. So same thing happened there also. Neonatology started getting more focus, and Downey Vidyasagar was a result of a grant given to Dr. Vidyasagar during that particular time. So this is there is some history behind this particular score also. I think that's that from my side. We can go to the next slide.
Sir. Patient was shifted to KMC ward. Mother was explained regarding KMC. Supplements were added. Weight monitoring was done, which showed adequate weight gain. At present, patient is vitally stable, takes BF well with adequate urine and stool out.
Shruti, just one odd question. Is that you started feeds of the baby on day 2, is it?
Yes, sir. As soon
Okay.
as the oxygen.
Why not day 1? No, I'm just asking. Like, it's fine, absolutely fine. We were not commenting on the
Oh,
processes that you follow. Just, I mean, uh, inquisitive, like curious to know.
sir, if there is somewhat distress, we just hold the
Okay.
feed for 5 to 6 hours and then we start.
Okay.
I
Okay.
used to start
So,
in TTNV cases. We used to hold feeds for at least 6 hours, and then we start once the patient is vitally stable.
so
There is no.
by and large, these days we are moving more towards feeding. Okay.
Yes,
Particularly
sir.
this big baby, 1.3, 1.4 kilo baby, 34 weeker. Most of us would have started on feeds from day 1. Okay.
Yes.
So actually the respiratory part and gut don't kind of confuse them. Like it has to do
Yes.
with gut and not really with the lungs. Okay, fine.
Okay, sir.
As such, this baby, I mean, I can understand if the baby is, having severe respiratory distress, you are about to intubate and all those things, then you hold feeds and all.
Yes.
Otherwise, this baby is relatively stable, just mild distress. So why would you stop feeds? Okay, unless again there is some history of some absent or reversed endospheric flow. If those problems
Yes,
are
sir.
not there, baby is not in shock, and baby is not in great respiratory distress, which would require immediate intubation and all. So one generally tends to give more of feeds, and mostly most of us would have started on feeds. Okay, it has got implications because if it is a very high volume, unit of yours, there the more you keep the babies on IV fluid and all, the more chance of infection and those kind of things. And also babies go, you start feeds early, you can discharge babies earlier. They gain weight better. There's a lot of advantages. Okay, so in the same context, I want to ask: are you aware about something called MEN?
Minimal enteral nutrition.
Okay, so what is it and why it is done?
Sir, it is done in preterms, just for gut priming,
Very
and
good.
it decreases the chances of NEC in preterms.
Okay. So basically it is given for priming of gut, not for nutrition purpose, but for
Yes.
priming of gut. And it is done when you don't want to start full feeds, but you want to give
Yes.
something for priming of gut. And you correctly said preterm babies, like quite preterm babies, extreme
Hmm.
or moderate preterm babies. So how does it help? What does it do actually? How much feeds you give in MEN?
So 1 to 2 cc 6 hourly IRT, sir. six
Is it
hourly
same for
for
a 500 or not? Let's say 600 gram baby and 2 kilo baby. So roughly about 10 ml per kg. Okay. So
yes.
about 10 ml per kg. That is what is called MEN. So it will differ. I mean, for a 1 kilo baby, maybe 1 ml too early, or and for a 2 kilo baby, it will be different. So it is about 10 ml per kg. Some people say 10 to 20 ml per kg, or 5 to 20 ml per kg. So it's very minimal milk is given, not for nutrition, but for something else. What does it do once it goes to the gut? How does it help? How does it prime the gut? What does it do inside? So it basically improves peristalsis. It improves all those
Yes.
enzymes. Those are there inside. So, and then the mucosa inside, it gets rejuvenated. All those things. So the mucous membrane, the enzymes, the peristalsis, the healthness of the gut. Everything improves. Okay. So MEN actually is a very good thing in case you are not able to give feed. So just keeping NPO, unless it is like, the situation is so that you have to keep NPO, like in surgical
Yes, sir.
cases, or there is reversal of end-diastolic flow in less than 34 weeks. Other than that, it is generally considered that you start on full feeds or at least give MEN, but don't give NPO. It's not considered to be good. The gut mucosa, they get atrophied more, you give NPO. Fine. Okay. Second, I am really very impressed by the fact that you started explaining about KMC.
Yes,
Very
sir.
good. So how does KMC help? What is KMC?
Uh, Kangaroo mother care, sir.
Very good. Kangaroo mother care.
Um,
So what is it? What is done in that?
so baby is kept between mother's breast in a frog position, sir.
Yes.
And it promotes mother baby bonding, sir.
Very
It
good.
increases breast milk production, sir.
Very
And
nice.
stimulation to the child, sir, and weight gain,
Yes.
and it
Yes.
acts at a human incubator. And
Yes. So
it
you
decreases the
you said
hospital stay.
very good. It reduces hospital stay, it reduces mortality, it reduces chances of hypothermia, and it stimulates the baby by many means. Can you tell about that? How does it stimulate? What all
So
stimulation baby can get?
tactile stimulations are sight,
Touch stimulation,
smell,
very good.
sight,
Sight,
smell.
smell. Baby can look at the mother. Baby can
Yes,
smell mother. Baby can smell mother's milk, mother's body odor. No?
yes, sir.
Then what else? Then baby can perceive all those heartbeats of the
Uh,
mother. No?
yes, apnea. It
Then
prevents
it
apnea.
prevents apnea. No, I'm asking about the stimulation part. So it almost all the sensations baby gets. No? Baby is kept
Yes.
upright. So postural ones.
Mm,
Then all those tactile, visual, hearing.
yes, sir.
You can hear also mother's heartbeat. In fact, mother can speak, mother can sing, mother's
Yes,
voice it can hear. So
yes,
every indriya, you say na indriya, every
yes, sir.
sensation, it. So KMC is such a low cost and such a nice thing. Every preterm baby should undergo KMC. No,
Yes,
like mother's milk, it's so, I mean, available everywhere, and it must be done as many hours one can. Okay, and very nice that you kind of explained about KMC and you started also on KMC. No? So it's a
yes.
very nice thing to do. Yeah, I'm finished. Maybe Dr. Ravindran sir.
Very good, very good. Continue with the slides, ma'am.
Yeah, wait, I'll ask. So you talked about KMC ward. So is a KMC ward necessary for giving? So when you talk first, is a KMC ward necessary for giving KMC?
No, sir. Anyway, available.
No. So where locations where you can give KMC?
Sir, it can give home.
Okay. In the NICU also next to the baby, next to the
Yes.
bottom you can give. Yeah.
Yes, sir.
So as was asked for nutrition,
Yes.
why full feed were not started on day one. I
Mm.
want to ask why KMC was not started on day one. What is IKMC? Have you heard of something called as IKMC, like iPhone, iPad? वैसे IKMC होता है कुछ, comes from the US.
Sir, actually, yes, I have heard about it, but I haven't read about it, sir. But
Okay, so
heard
you
about
don't know about IKMC. All right, so I'll tell you in brief. Maybe I can share slides later on if
it.
there is
Yes.
time.
Yes.
So IKMC is basically, especially for this particular baby, IKMC would have been very good. Uh, in, in I think about 10, 12 years back, 2012, 2013, there's a paper published from South Africa where they started KMC for premature babies, 1 kg, 1.2, 900 grams, small babies. And they started right from birth, right after delivery, and continued KMC, and the baby remained in KMC position all the time till discharge for most of the days. They replicated this particular study in Vietnam, which also showed better improvements for the premature babies in in both the randomized controlled trials. So based on this, in 2016, WHO funded a large trial across various countries, including India, Bangladesh, I think some uh, Sri Lanka and Malawi, if I'm not wrong, 4 or 5 countries, where they decided to do IKMC. If I remember right, it's 1 to 1.8 kg babies that were in this trial. Half the babies got randomized to uh, KMC right from birth, immediately after birth. Like this baby would have gone into IKMC immediately after birth. Even if distress was there, mild distress was there, we would have received CPAP or any even ventilation on the mother's chest, and baby would have been shifted to what is called as the MNICU, mother and neonatal ICU, where mother and neonate are kept together all the time, and both are kept together in a single area. And these were large rooms and not like wards or the way our NICUs are currently structured. So this happened in Safdarjung in New Delhi, and this IKMC study was published in 2021 in April, which showed, and this was one section of the babies who got immediate KMC. The other section in the other control group got KMC like you gave. So baby went to warmer, so or and then remained for 1 or 2 days and then got KMC. So that was babies in that is generally what is referred to as KMC given to stable babies. Okay, so the other half received stable KMC. So both the groups got KMC in the IKMC trial, but the babies who got KMC right from birth had that group there was 25% lesser mortality. So there were more babies who survived in that particular arm as compared to the babies who got KMC after being stable. So one of the issues is so what I wanted to tell you is that baby could have got KMC on day one. It might not be actually IKMC. Like baby comes to the NICU. After a few hours, you decide the baby is stable and then start KMC 6 to 8 hours later. So that would still not be IKMC. In IKMC, would start giving KMC right from birth, shift the baby in KMC position from delivery room to the MNICU and continue in that position, do all your stuff there itself. So the point is the earlier you start KMC, the benefits of KMC increase. I also want to share that number of hours of KMC that you give to a baby. Like baby stays in you said home KMC can be also given. So this baby 1.3 to reach 2.5 would take some time, 1.5 months at least at the minimum. And if the baby receives KMC, it will reach that bit faster. The number of hours of KMC that is given increases the amount of brain tissue in the brain. So this has been shown by scans of adolescents who received KMC when they were born prematurely. So the people have followed up babies who were preterm were followed up during the adolescence, and those who received KMC, their brains showed a larger caudate nucleus as compared to babies who did not get KMC. And in those babies who got KMC who had a larger choroid nucleus, the size of the choroid nucleus correlated directly to the amount of KMC hours that the baby got. And so the point is that it is dose dependent. So the more the dose of KMC that he gets, the benefits are more. So that's what I wanted to kind of share. Yeah. So weight monitoring showed adequate weight gain, you said. I'll not
Yes.
ask for questions here. Yeah.
No history of any hereditary or major illness, recurrent blood transfusion, jaundice or tuberculosis. No history of neonatal death in any family or developmental program.
So Dr. Ravinder and Dr. Shaw has left, so you'll have to start.
Yes. Yes. Just one thing, in this particular case, what are the significant family history you will ask? Pertaining
Sir,
to the
history of twins yeah, on maternal side.
okay.
Uh,
Jaundice specifically, anything you want to ask about jaundice? And jaundice running families?
uh, no, no, sir.
Not so common.
Yes, sir.
But in this case, I'm agreeing because this is a primary mother. If it is a
Yes.
second baby and the elder sibling has a jaundice, that is significant, not significant. This particular baby in which
Yes, sir.
you go back to your history and just think on if this particular case, the mother had a second baby, a first baby, and
Yes.
first baby had a history of jaundice. Do you think this baby has got a higher risk of jaundice?
Yes, sir.
How?
There's some family syndromes which are related with neonatal jaundice, sir.
Okay, I agree with that. But just particularly about your blood groups.
RH incompatibility
Right.
or ABO incompatibility.
So the subsequent pregnancies, they already exposed, particularly in RH particularly. Subsequent pregnancy risk is more compared to
Risk
the first.
of, yes, sir.
In case of RH particularly more compared to
Yes.
the.
Yes, sir.
I ask the question. The mother is O positive, baby is A positive,
Yes, sir.
and mother is O positive, mother is O negative, baby is O positive. Mother is O negative, baby is A positive. Which is better? Mother is O negative. One mother is one baby is A positive, one baby is O positive.
O negative and O positive.
O negative and
No,
A
no,
negative.
O negative and A positive.
Okay, is better compared to O negative and O negative. O negative and
Yes.
A negative is better.
Yes.
Very good. How can you answer?
Sir, actually, I don't remember it completely.
Very good. But your answer is
I
correct.
read it somewhere or I have heard it somewhere, sir. If there is ABO incompatibility in presence of RH, the severity of RH incompatibility decreases, but I exactly don't remember the mechanism and stuff. I have read it somewhere or I have heard it somewhere.
So there are type of antigens, which is
Yes.
immunoglobulins, which is crossing
Yes.
the baby to the mother, and
Yes.
mother is ready to make antibodies for the next baby. So when there is a AB incompatibility, that sites of antigen binding sites will be occupied by the
Yes.
antigen, and that will cause less difference of jaundice. So
Yes.
O negative will have more, O negative, O positive will have more jaundice compared to
Yes.
negative A positive. Right. So this family history and family history of gallstones, family history of patient blood transfusion, family
Gallstones, hemolytic anemia.
hemolytic anemia, family history
Yes.
of multiple blood transfusions.
Yes.
You agree with me? Particularly in case of
Thalassemia.
leukemia, abnormal, very good, excellent. So you're coming towards the hemolytic type of jaundice. So hemolytic jaundice means RBC is getting destructed.
Yes.
Agree? So what are the ways
Yes.
which RBC can get distracted? What are the causes?
Sir, extrinsic cause or intrinsic cause. Intrinsic cause, there is any defect in the RBC itself, whether it is related to any membrane or a hemoglobin. The hemoglobin, it is made up of a heme plus globin. Any defect in the globin chain, which leads to ineffective erythropoiesis, which leads to destruction of RBCs, sir. Or in any extrinsic cause, it is due to either antigen antibody related RBCs destruction, or uh, in case of G6PD deficiency, in case.
So intrinsic cause, you told RBC has got a membrane. Inside
Yes.
the RBC, there is a hemoglobin. And one
Yes.
more thing inside the RBC is the enzyme. So membranopathy, enzymopathy,
Yes.
globinopathy. Membranopathy is phagocytosis, erythrocytosis.
Yes.
Hemoglobinopathy is thalassemia,
Thalassemia, sickle cell anemia.
and enzymopathy is G6PD deficiency.
G6PD deficiency, pyruvate kinase deficiency.
Very good, very good. So the three things are causes for intrinsic RBC damage. Extrinsic, you told excellent on the antigen antibody reaction, all this.
Yes,
Right.
sir.
These are all causes of hemolytic.
Yes.
What are causes of non-hemolytic jaundice? How will you classify?
Cholestasis.
Which organ you will divide as a center part? Which organ will be pre, post, pre dash, post,
Pre, post, and hepatic jaundice.
pre-hepatic, hepatic.
Uh, and post.
Right. Right. Continue. Continue.
Next slide. Baby has universal flexion examination. Baby has universal flexion posture with state of wakefulness. Vitals. Baby is peg and temperature is normal. Heart rate is 124 per minute regular. Respiratory rate is 40 per minute. Periodic. CRT less than 3 seconds. Gestational age by modified Ballard score is 32 to 34 weeks, and no icterus, pallor, cyanosis, or edema.
At the time of examination, there is no jaundice.
Yes, sir.
At the time of examination, there is no jaundice. The jaundice has been treated.
Okay. Yes,
I'm
sir.
asking you, babies had history of jaundice, was giving phototherapy or no
Yes,
history of jaundice?
sir. I examined the patient at 70th day of life. At 4th day of life, patient had a history of jaundice, and the patient was kept on phototherapy for the same.
For how many days?
For 24 hours, and then it was omitted.
So taking this history, 4th day appearance, 5th day disappearance. It is physiological or pathological?
4th day, it's physiological, sir.
Yeah.
And in case of pathological, jaundice appears within 24 hours.
Right. Correct. So time of onset, time of disappearance. So what
Yes.
is the onset of physiological jaundice?
So due to decreased conjugation of bilirubin,
Okay.
immature hepatic enzymes, increased destruction of RBCs, uh, enterohepatic circulation, uh, uh,
Excellent.
in case of
So increase production, decrease excretion,
yes,
and impact conjugation.
yes.
Now, when it appears, what is the time of onset of physiological? When the time it disappears?
Uh, third third to fourth day, sir, it is maximum, and
Very
it
good.
disappears within 14 days.
Excellent.
Yes,
So appears on day 1, peaks at 4 days, disappears on 14
14 days.
for a preterm, 10 or a term. So the opposite is pathological jaundice.
Pathological jaundice.
Pathological jaundice is less than
24 hours, and it persists even after 14 days, sir.
name 3-4 causes of pathological jaundice, you know.
uh, RH incompatibility, sir.
Hmm.
Uh,
Just now
uh,
we enumerated what type of jaundice is all are pathological. Just now we discussed na
yes,
classification
sir.
of jaundice. Hemolytic, post-hepatic, pre-hepatic,
Uh,
all are pathological.
Pathological jaundice.
And what is jaundice and icterus and hyperbilirubinemia? Both are same, all are same or different?
Uh,
So jaundice is defined as
uh, 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 sign which we
it is a dash discoloration of
uh, sclera
skin
and
and sclera.
skin.
Very good. Very good. Skin and sclera. Jaundice is yellow. My skin is yellow, I'm having jaundice. My blood is having bilirubin, that is hyperbilirubinemia.
Yes.
So sometimes baby's blood level will be high, skin will not be yellow. So not all hyperbilirubinemia will be visible. So
Okay.
sometimes bilirubin may be hyperbilirubinemia is different, and the
Oh,
yellowish discoloration is called jaundice.
yes.
Can you tell some condition where the skin is yellow but jaundice is not, but bilirubin is normal?
Sir, in case of hypercarotinemia,
Very good. Hypercalcemia. Often they come to the OPD applying turmeric for newborn baby also.
yes, sir.
That is atrogenic. Baby may look yellow.
Yes.
Right.
Yes.
So this jaundice we discussed, classified. And why you are worried about the posture for the jaundice baby?
Posture.
Yes. You told
Uh,
flexion posture.
Sir, in case of kernicterus, often the tonus posturing of the baby occurs if that indirect bilirubin is deposited in the basal ganglia and it has started to affect the baby.
So that is not the its good side. Okay.
Yes, sir.
And what is, can you tell one or two lines about Ballard score?
32 to 34 weeks, sir.
Why Ballard score
Neuromus,
is very good? Tell about what are the things you will see in the Ballard score.
sir, neuromuscular maturity, sir, popliteal angle, scarp sign, heel to ear, sir. Uh, scarf sign, to ear.
Posture,
Posture,
right, at a triangle.
adductor angle, sir, and physicals, scale, breast bud, skin, genitals, linguo, ear recoil.
Very good. Almost you have covered everything. Okay. So that is important for gestation age assessment. Okay. So what day you will do Ballard score? Day 0 or day 1?
Sir, day 0.
Early as possible, preferably after 24 hours, 24 hours. So when the
Yes.
baby is just little out of the 24 hours. Okay, right. Continue.
The weight is 133. Anthropometry, sir. Weight is 1335 grams. Length is 40 centimeters and head circumference is 30 centimeters. And the baby is SGA.
Just tell me what is the ideal measurement method of weight checking, ideal measurement of length checking, ideal measurement of head circumference checking.
The weight, though, uh, we place a cloth and then we place the baby on it so the baby does not suffer from any hypothermia, sir.
Very good.
And head circumference is by taping from occiput to supraorbital ridge by cross tape method.
Very good. Length is
Uh, Infantometer, sir.
so infantometer. There is the mobile part. There is the fixed. Which part will keep, head in the mobile part or fixed part?
Head at the fixed part and legs, mobile part is at the legs.
Right, very good. So this anthropometry you are doing at all maybe daily or sometimes how frequently you have to do?
Uh, Sir, we do it daily. In case of NICU admission, we do weight, length and head circumference at within 24 hours, sir. And then weight monitoring is done, and head circumference is done every 7 weekly in case of high risk newborns which are admitted in the NICU. And all PNC admitted patient also we took take the anthropometries.
Head is small, you're happy or worried?
What, sir? Sorry, sir.
Head circumference is small, you're happy or worried?
Sir, worried.
So what do you think of the head circumference is there?
Microcephaly.
Okay, very good. So microcephaly can be two types. What are two types of microcephaly, you know?
Sir, familial and patho, or it may be secondary to any pathology, brain
Very good.
pathology.
Primary and secondary.
Yes, sir.
Primary and secondary. So how we differentiate this baby's head is primary microcephaly, this baby is secondary microcephaly.
Uh, Sir, in secondary uh, uh, microcephaly, there is any history of perinatal events like
Hmm.
birth asphyxia, cerebral palsy, uh, or any MRI suggestive of any brain anomaly. And in case of familial, development is normal. Uh, Patient is as such normal, sir. No other CNS abnormality is seen.
Have you seen microcephaly babies with the slanting forehead and straight forehead? So one baby is having slanting forehead, one baby is having straight forehead. Both babies are having microcephaly. Have you seen the difference babies? One baby is having flat head with the microcephaly, one baby is having slanting head with microcephaly. So if the baby is having primary microcephaly, it is the slanting forehead. Secondary microcephaly, it is the understood. Right.
Yes.
And you're worried if you see the suture. You're happy if you're overriding, or happy if there is a bulge end. I'm having the microcephaly baby will have a suture overriding. Suture overriding is like step like this.
Yes,
Bulge
sir.
is like one step above, one step below like this. This is bulge.
Yeah.
There is one step above and one step down.
Hmm. Hmm.
So when you are worried, and this is overriding you're worried, or when there is a bulge here. Overriding it is okay. Maybe skull can grow again.
Yes.
When there is fused and bulge happens, then there is difficulty for the baby. So when you see the palpate, whenever you see a small baby head, just palpate the sutures. The sutures are going like a step. You're happy. The sutures are going like a step and coming down, like a U, like a omega,
Yes,
like
sir.
omega. Huh? Then you're worried. That baby may have vision problems in the future. Okay, right. Continue,
Yes.
please.
Uh,
Yeah.
like
So about head circumference, is there a question being asked? I thought it is over. Sir, you are not heard. You are not audible. I don't know.
So I asked about the type of car. She told correctly the cross tape method and a non-stretchable tape. That is better. On the Frankfurt plane also she told correctly.
So my question actually to Shruti is for this reason.
yes.
Head circumference, which you mentioned 30 centimeters. And we talked about nutrition on early feeding on day one.
Yes.
And we also talked about KMC on day one. And so what are the relation of this feeding KMC to head circumference and ultimately to neurodevelopmental outcome?
Sir, breast milk is important. So breast milk leads to good neurodevelopmental outcome. KMC will promote increase breast production, milk production, sir, and early feeding breast milk.
So I don't know. We talked about growth curves, but we did not talk about extrauterine growth restriction. I don't think we discussed that. So the curves that you showed, we discussed the growth curves. What commonly happens for these babies is because we don't start nutrition early, because they don't get enough KMC. They don't gain weight. This is I think 6, 7 day old baby, right? But with these babies gaining weight on a regular basis, they do not gain weight at the same rate as they need to be gaining weight if they intrauterine. That is one. Even in the extrauterine growth period, if they gain slower than what we expect normally of them, of when everything is done properly, it leads to a lesser head circumference at 3 months, 6 months, 1 year of age. Is there a relationship between head circumference at 1 year of age and neurodevelopmental outcome? There is. Okay, there is a
Yes,
big,
sir.
and smaller heads make for poor neurodevelopmental outcomes. And this is directly related to feeding in the newborn period, KMC. So KMC basically increases milk output and ensures faster weight gain. So it's just a proxy for whether weight gain is happening properly or as much as it needs to be. And hence, uh, getting the babies to gain weight properly using breast milk and so people can get formula fed and can gain weight very rapidly later on, and that is not appropriate because that causes other issues. So that is not what I'm talking about. I'm talking about baby getting uh, uh, mothers giving KMC, increasing breast milk output because of KMC in the mother. That a good amount of feeding or to the baby right from day one and not like day to day three. And this all causes impressions on weight gain, and that will indirectly cause head circumference and height also. And height is actually not related to uh, this is not really medical stuff, but social sciences research shows that those people who are taller will always make the more money, even if they do not have that many degrees. Okay, you might be smart and you might have more degrees than a person who's taller, but the taller person might end up making more money than you. So that is again relates to your IQ. So all these are related in many ways. So hence, nutrition becomes very important in the first 2 years of life and later on up till 5 years of life. That becomes very important. Yeah, I think that's next.
Shruti, can I ask this one question? Sarah was talking about microcephaly. You had discussed one drug already, uh, which can,
Thyroxine.
okay, any other drug okay, have you given to the mother multiple times can cause this. Which drug was
Microcephaly.
which drug was given to the mother here? Sarah was asking about the benefits of the drug given to the mother.
Steroids.
Steroids. Yesterday I'm asking, like TT injection, why don't we give every mother monthly one steroid?
I actually wanted to ask that, then I said I'll leave it. So good.
I'm just asking, just what I want. I know that you will answer correctly to my question. Tell me, every 6 months, 7 months, 8 months, one dose of steroid you can give, na? So, can you tell me what is the problem?
Mm.
Poor
We can
neurodevelopment outcome
poor
Correct.
neural outcome. Very good. So,
and
too
risk
much
for cerebral palsy also increase.
risk is there's a lot of headache of giving multiple dose of steroids. That is
So
reason.
5, 10 years back, a lot of gynecologists used to give like patient to come at 29 weeks, 30 weeks, and they felt that there might be premature delivery. So they'll give one, they'll call next week again, give one, they give three, four, and many people used to give multiple. Only a lot of people used to give two or three. And what is seen that even if you give two or three repeated steroid injections during pregnancy, and even if the baby delivers, that would, as Dr. Asnodkar as Asoltekar has said, causes poor neurodevelopmental outcome. Okay, so that's it. Yeah. What else I wanted to say about something is, I think we'll go ahead. Anything else? We have discussed this, right?
Uh,
So
Sir,
yes, sir. What is the importance of the caput or cephalometoma in this case, particularly for jaundice baby?
so cephalometoma leads to pathological jaundice, prolonged jaundice. Uh, in, ca-
So can you tell one more differential diagnosis for caput or cephalometoma?
uh, Sir, any injury to the skull,
Okay, causing what type of hemorrhage?
subgleal or
Subgaleal hemorrhage. Okay. Subgaleal hemorrhage, caput, cephalometoma, and one more thing. I'll be happy if you use the term. The obstetrician is putting a vacuum. Baby head
uh,
is having a
Chignon.
different signal. Very good signal. So four things are there. One is caput, one is epilemotoma, one is chignon, one is
Subclinical hemorrhage.
subclinical hemorrhage. Okay, right.
So have you seen subgaleal hemorrhage by any chance?
No, sir, I haven't seen.
Yeah, so we don't see it longer because I think most people now just go to cesarean rather than try vacuum or any other. So
Eye, ear, nose, mouth normal, sir. No facial dysmorphism is seen. Neck and chest normal. Skin normal. Umbilical cord right. Back spine genitalia normal. Limbs normal. And anal opening was normal.
umbilical cord is dried. So any stuff that you know about umbilical cord? There was any medication applied to umbilical cord? Should be applied, should not be applied. Any,
Nothing should be applied to the umbilical cords.
okay.
Umbilical cord falls off by what mechanism?
Uh,
Okay. Have you seen diabetic foot? Black color,
yes, sir. Yes, sir. Gangrene. Dry, wet or dry gangrene.
otherwise known as necrosis.
Cell death.
Necrosis. So this is what type of necrosis? Umbilical cord. It is necrosis secondary to infection. This is necrosis without infection. It's called as
Okay, sir.
aseptic necrosis. The umbilical cord falls off,
Yes.
but the skin bacteria will go and multiply
Yes.
on the bacteria umbilicus, and the umbilicus becomes necrosis and aseptic bacteria. Aseptic. We don't apply Dettol, don't apply anything.
Yes.
Okay. I'm talking about bacteria multiplying, but I'm not telling asepsis. Is it correct? I'm telling just now I told skin bacteria will go and multiply and umbilicus and umbilicus becomes necrosis and falls. Still I'm using some asepsis because blood is not having multiplication of bacteria. Multiplication of bacteria in the blood is called sepsis. You agree with me, Shruti?
Yes.
Sepsis is blood having multiplication of bacteria is called sepsis. Blood is not
Yes.
having bacteria. Only the skin bacteria is going to the umbilicus and multiplying, and so blood is asterile. That is called aseptic necrosis. Okay.
Necrosis.
So somebody is asking, shall I put that on? What will you tell?
No, nothing should be applied.
Very good. Next.
Okay.
Systemic examination. Chest wall movements symmetrical. Air entry bilaterally equally in all areas. CVS examination. Heart rate 140 per minute regular. S1, S2 plus no normal. Abdominal examination soft, no abdominal distension, umbilicus NAD, liver spleen not palpable.
Kidney,
No, no, sir.
you palpated for.
No, sir, not palpable.
Okay, I'm just asking because most times the only time when kidneys are palpable is in newborn period. Others is very unlikely to palpate kidneys ever in normal human beings.
Yes.
So anyway, so that's. But suppose you were to do abdominal examination, find some masses, bilateral masses. So what is the most likely diagnosis that you might have?
Bilateral masses. Sir, any tumor?
Yeah, so you should again, because I mentioned kidneys, you should say that if they're palatable, they're likely to be autosomal recessive
Lymph tumor?
polycystic kidney disease. Those are most common. It's not uncommon. You do get them.
Yes.
All right. And suppose you find hepatosplenomegaly, the baby has microcephaly. So then what do you suspect?
Uh, Sir, inborn error of metabolism. Lysosomal storage.
So you can have infections. So those are the things you should start thinking of.
Okay.
We are coming to the close. We have 12 minutes. It's not that we can continue beyond 8 also. We can go until 9 o'clock also. So don't
Sir,
worry. Yeah, please go ahead.
neurological examination, wakefulness, crying, patient was active, no apparent facial palsy or eye movements, spontaneous limb movements was present, ma'am. Reflexes, sucking, rooting was present, Moro's was present, startle reflex was present, palmar and plantar grasp was present, and asymmetric tonic neck reflex was present.
Shruti, can you tell what are the different types of Moro you know?
Moro's,
Different types of Moro.
so complete, incomplete.
Very good. In what gestation can it complete?
Sir, after 28 weeks of
Okay.
gestation.
So that is one classification. Second classification.
Asymmetric, symmetrical.
Very good. What are the conditions like asymmetric Moro?
Sir, in case of Erb's palsy or fracture of clavicle,
Very good. Another one more classification of Moro.
I don't know.
So here you're able to do Moro at usual what degree you will do Moro?
So 30 to 40 degree.
30 to 45 degrees you drop. Okay. But the baby is not able to do Moro at 45. But if you do at 70 or 80, the Moro is elicited. It is called weak Moro.
Okay.
And the baby is able to do Moro at 10 degree itself. Strong Moro. Okay. So weak Moro means Moro is not present at 45, but
Yes.
present at 60 or 70 or 80. Strong Moro is when you just lift the baby a little bit and drop, immediately the Moro reflex. It is called strong Moro. Okay. Strong Moro. Moro is what type of leg reflex actually?
Primitive.
Primitive or what phenomenon? The brainstem release phenomenon. Okay.
Brainstem. Yes.
Right.
So I actually wanted to say something and I had forgotten. So that when we were discussing steroids, so I just wanted to share uh, that receptors. So there are all of these drugs, etc., act through receptors, and especially for anticonvulsants, there are excitatory receptors and inhibitory receptors. Now we should understand that the baby is developing in utero, and many of these receptors where our drugs act actually change kind of character. So even for steroids, uh, as the baby's prematurity changes, maturity changes, the way hydrocortisone injection will affect a 28, 29 weeker will be different from the way it affects 32 to 33 weeker, because as the gestation changes, the receptor character, whether it becomes positive kind of, it affects it positively or it affects negatively. So all these things change. So the reason what I want to share is many of the drugs that we use, we have no idea as to how they work in the fetal period at different stations. So even though we say preterm baby, a preterm baby is not a preterm baby. A preterm baby is a 26 weeker or 28 weeker. So all those weeks babies are different from each other. So and the reason why we should about this is most of the research that we see currently and that is published is babies basically between 26 to 30 weeks of gestation. While all of the babies that we see in our NICUs and we look at and are basically 30 to 34 weeker, which are different. And all the studies that we see then in international journals, many of them don't apply to our situation. So this is something that we should understand. We have seen that happen for therapeutic hypothermia. What is supposed to be useful in the West, not seen to be useful in public health settings in India. So, comment by the side.
The diagnosis. Neonatal hyperbilirubinemia in background of ABO incompatibility with low birth weight care in preterm, 32 to 34 weeks, LACS, FCH, cried immediately after birth weight 1634 grams.
I have a question here. Shruti, can you tell me what is chronological age? What is post-menstrual age? What is corrected age? What is post-conceptual age? What is post-menstrual age? Post-menstrual age means baby delivered at 32 weeks. So 32 weeks is post-menstrual age.
Okay.
Chronological age is baby is 17 days of life.
Okay.
So 17 days is a chronological age as per the day of life. And what is post? See, the baby is not reached term. Baby is not reached term in the sense baby has not reached 17 days is actually 2.5 weeks.
Mhm.
So 32 plus 2.5 is 34.5.
Yes.
So baby is not reached term. So baby cannot expect head control. Baby cannot expect that social smile at extra 6 weeks. Baby has to get social smile once the baby reaches 40, then 6 weeks. Baby will get head control once the baby reaches 40 from the 3 months. So for that we have to use the corrected age.
Correct. Yes.
Corrected age is baby still not reached corrected age. So corrected age is when the baby reaches 40 weeks. From there we calculate. So baby is still not reached 17 days of life, still not reached corrected. So there are post-menstrual age, chronological age, and corrected age. Right. So what are the history handles you are having that is substantiating your diagnosis? Jaundice, history favoring jaundice in this child is?
So this is what you were trying to say, right?
Yes, sir. Yes, sir. So what sir is trying to put is definitions of various types of preterm and term.
Yes, sir.
So once they reach 40 weeks, they complete the term. After 40 weeks, it's the post-corrected age. Post-conceptual age is correct. It's a corrected age. After 40 weeks, day starts. So what is difference between extreme preterm and very preterm? And your baby is...
You want me to show the slide?
Yes. Okay.
Late preterm.
Yes. So what is the difference between the three preterms? So less than 32 is worrisome. Less than 28 is more worrisome. Extreme preterm.
Yes, sir. Yes.
28 32 is very preterm.
Yes.
And your baby is?
Late preterm, moderate to late preterm,
34 to 37. So that is moderate to late preterm. Okay. And term is 40 weeks. And post term is 42 weeks. So a baby is EDD, you know EDD, na? Expected date of delivery. The date is given, for example, on March 3rd. Baby is delivered on March 4. You cannot tell post term. You can tell post dated.
Okay.
When the baby is delivered 2 weeks after the date, it is called post term. So after 42 weeks, it is post term. After 40 weeks, it is called post dated. EDD is March 3rd, baby delivered March 4 is post dated. EDD is March 3rd, baby is delivered on March 18 after 14 days. Then it is called post term. Okay.
So this is what we want, adult outcomes of being born late preterm. So all the otherwise also. Okay. And India has the maximum number of premature babies. Let's stop here.
So what Sarah has put very beautifully, a preterm baby, very small now, suddenly become fat in the future. Is it possible?
Yes, sir.
How? My baby intrauterine, there is a growth restriction. Afterwards, at 25 and 30 and 40, he becomes obese. How? So if the baby is small, how the insulin will be programmed for low glucose? I am small means my body is prepared myself for low glucose. After delivery, if I eat more and more, or even if it's normal also, that becomes extra. Understand? For my body, my insulin is programmed such a way that it is catering only this much. But after delivery, I take normal diet or high diet. It's called Barker hypothesis. So, baby is programmed for intrauterine growth restriction for low nutrition. After delivery, the baby receives normal nutrition or high nutrition, baby becomes obese. There are obese, hypertension, coronary artery disease. Three things, okay, that can happen. Type diabetes. That's called deadly quarter. Obesity, hypertension, type 2 diabetes, and coronary artery disease. This is the risk factor of late preterm.
Okay, stop sharing this one. Uh, we are towards the end, and anything else? I can show us slides, but I think
So you have beautifully classified jaundice into hepatic and post-hepatic, pre-hepatic, hemolytic, non-hepatic. You have beautifully explained the types of oxygen you have given for preterm and term, and you have described the SGA growth curves and answered correctly about various questions we interpreted in between.
good. Thank you very much. So this has been excellent, and
Very good
I
presentation.
so basically we wanted to deal with a normal premature baby, not normal, but premature baby, which we generally see and discuss the issues. We dealt on mainly steroids and how steroids are important. We dealt on how nutrition is important early. KMC, we looked at uh, various antenatal factors that we discussed. Uh, any last closing points that you wanted to mention, Dr. Rabindran?
Yes, sir. One question. This baby is going home
Yes,
today.
sir.
What will you advise a mother? What are the things you ask them to come for follow-up?
Sir, KMC, weight monitoring,
Very.
supplements,
Hmm.
ROP, OA, um, oil massage.
Any scan you will ask them to do?
Uh,
Less than 32 weeks, you do neurosonogram.
okay.
And rest of the things you told correctly. And they should come for developmental follow-up, or they don't want to come developmental follow-up. High-risk clinic,
Yes, they will come, sir.
you will come to the high-risk clinic. Okay, right.
So again, related to jaundice, I wanted to ask, should you use
Yes,
those
sir.
charts in jaundice, na?
Yes, sir. Sorry, sir.
Starts,
Use the
starts.
jaundice, na? Phototherapy देना है कि नहीं देना है, and all the charts.
Yes. Bhutanese chart, sir, we use.
You know who's Bhutani?
No, sir.
Again, an Indian, Vinod Bhutani from India, who went to the US, and is a lot of research on this particular area, jaundice. So Bhutan is not a US name; it is an Indian name, Vinod Bhutani. Okay, so I thought it's some additional stuff. Good. It's been interesting, and actually follow up. I think we can discuss in detail even more. That would probably take another hour of what to do in follow up, what we should be looking at, when we should call them. Uh, so, do you have a blue book, by the way? Something called as a blue book for follow up.
No, no, sir.
I'll try and share that. Let me check. This is what you should get. I have your WhatsApp. I'll share it with you.
Okay,
Uh,
sir.
that is something. So this is from Trivandrum. Uh, that Naveen had given it to. We have our own blue book also. Uh, I'm not getting the blue book here. And I'll share the one which, wait, let me just check. Uh, don't have it. I mean, I can't search it right now, but I have the blue book which I can share it with you later at some later point of time. That is what we use for follow up. Okay. Thank you very much. I think we'll close the session. So I would like to thank Dr. Aditi for mentoring the student and ensuring that despite the initial difficulties, we have managed to cover what we wanted to cover over this period of time. Very thankful to Dr. Chandran for joining and staying with us till the end. Dr. Shaw left, but when he agreed for the meeting, he had said that he would have to leave early. So very thankful to him too. On behalf of IIP Gujarat, I would like to thank Clarnet for managing this thing, and I hope this video, which is available on YouTube, can be seen and can be utilized. Dr. Aditi, you want to say something before we close?
No, so thank you, sir, for giving the opportunity to present the case on this platform.
Nice.
It was
Thank
a,
It was good. It was very interesting, Shruti, and despite
yes,
the initial issues, I think we did a good job, and we ensured that we discussed all the important things. So you have answered all the things that we would want a PG to answer. So some of the questions which are not answered were probably not, we don't expect you to know. So don't worry about all that. So good. Thank you very much. And I look forward to your joining the next session next Saturday. Thanks a lot. Thank you, Dr. Rabindran.
Thank you, sir.